Hello, everyone, and I want to welcome you. My name is Cindy Marrow, and I will be the host and moderator for this ADEIL conference session. I want to apologize in advance because I'm having some technical difficulties, so that's why I'm not on screen, but hopefully everyone can hear me okay. I want to thank you all for joining us for increasing awareness of unconscious bias among healthcare students, and I want to welcome Tracy George, Claire DiCristofaro, is that right?
Yes.
Okay, and Pamela Murphy.
Thank you so much for having us today. Our topic, as we said before, was increasing awareness of unconscious bias among healthcare students. And we're going to each be doing parts of the presentation today. We have no conflicts of interest to disclose. And I'm going to let Claire move on next to slide 3.
Hi, everybody. So I'm going to take this first section of slides. Just to introduce us, I'm at Ashford University, as is Pam, and Tracy is at Francis Marion University. Francis Marion is a residential college of nursing and other programs in South Carolina, and Pam and I are distributed faculty as full-time remote faculty for Ashford. So we are going to look today at the importance of unconscious bias, also sometimes called implicit bias or unaware bias, but specifically in the healthcare setting. We did a study that used the Harvard-Wade Implicit Association Test, or IAT, to measure unconscious bias in nursing students. And the analysis was then done to look at various correlates to that test and implications for education, and educators then will be discussed further. Now, when we think about unconscious or implicit bias, this is actually something that's a bit in the news. And one of the things is that we're talking essentially about a prejudice or a preference or a judgment in favor of or against something, but you are not really aware. That's why it's called unconscious. So that's why sometimes it's called implicit versus explicit, or unconscious versus conscious, or unaware versus aware. And it could be a thing, a person, a group, but it's often, the idea is that this would be considered an unfair judgment, not based on objective evidence. So a lot of people over the years have said, well, we need to train people to not do this anymore. This is something that we can make sure that with proper education, a certain way that we raise people, things that we expose people to, this won't happen. And it turns out from a neuroscience standpoint, that's not actually true. We actually automatically make judgments all the time, and we're basing it on all sorts of experiences, background, things that we're also unaware of for the most part. And this automatic judgment occurs as basically a survival technique. We have to know, is it friend or foe? Is it a good situation, a bad situation, run away, stay put? So we're not going to stop our brain from making these automatic judgments. So one of the things to think about, though, is to become more, to recognize that this is happening. And then can we intervene and then hopefully not have our behaviors reflect such automatic judgments? One of the problems is if we don't recognize that this is happening, especially in situations where you have, let's say, public-facing disciplines, whether it's healthcare, whether it's criminal justice, any type of public-facing career, you're going to be penalizing some people, benefiting others. And usually the factors, and these are factors that have been studied, are class, gender, sexual orientation, race or ethnicity, whichever word you tend to use, nationality, religious beliefs, age, and disability. And so you can make these automatic judgments with very little to go on. When you think about conscious or explicit bias, most of us are certainly familiar with that. We'd say we have a deliberate prejudice. We would speak about it openly, or we'd speak about it with people that we trust. And typically this is exhibited towards groups that are not us, minority groups. On the other hand, there have been some studies that have shown that this type of explicit bias can actually be exhibited towards groups that are you. It's the same thing as your own group. So an obese person might be actually consciously biased against another obese person. So the thing is that when we look at the difference between explicit and implicit bias, are we expressing our views directly? Are we aware? That's one of the biggest things. How is it operating? So the thing is that explicit bias, somebody could come right out and say, I've been certainly a recipient of this. I was in medical school 40 years ago, and I was told in my undergraduate days that I should, before I went to medical school, that I should not pursue medicine because women were not good candidates for a medical career for a variety of reasons, mostly because this lack of seriousness was something that was very widespread as a belief. And I was told this directly without any hesitation. Implicit bias would, however, be acting in a way that you're unaware of that would possibly hinder or not promote women in the field. And now what we did was we put some interactive questions. We thought you might or might not want to participate in the chat. So if you have any experience with these questions that will come across during the presentation, we'd love it if you could type something to the chat. Have you ever focused on implicit or unconscious bias in your own classroom? What type of student, what class, and how did you deliver the subject content to bring this forward to your students? So we thought we'd love to hear from you if you've had that experience. So we wanted to give some background on why we actually did this study. And by the way, if you can also participate in the chat with anything, whether it's a comment, a question, a response to our question, the person who's not speaking, the other two of our colleagues will be monitoring and will respond. So our interest began because I had a very unsettling teaching experience. Typically, I have pretty positive experiences in the classroom, and I developed a discussion forum in an advanced healthcare class, graduate program, that basically was just trying to bring forward to students the existence of such a thing as implicit bias. And that I felt that this would be a valuable addition to their cultural sensitivity training. And so I asked them to take the Harvard Implicit Bias Test, any one of their choice, and then just basically post something about the results. Were they surprised? Did they agree with it? How was their experience? The responses were extremely intense. Some of them were hostile, bordering on unprofessional. And this was extremely unusual because all of these students were already practicing in their field, and they knew exactly how to be professional. And the people who predicted that they had no bias at all, in fact, did have a thin preference. That's actually something that's quite common. The prejudice against obesity is one of the more widespread and common biases. And they vehemently argued that the IAT, the implicit association test, was unsupported, was invalid, and that they felt that this was something that they could not accept at all. Other students, on the other hand, said that they felt that their eyes were opened and they recognized that there was probably something going on that they hadn't previously realized, and they did understand the importance of wanting to know about that. So I felt that this certainly was uncovering a really serious issue, that even in people who prided themselves on going to work every day and treating everyone in an equitable and fair way, that they needed to be aware that as human beings, they were going to have automatic judgments resulting in implicit bias. So we actually have seen research that looks at health disparities in the United States, and implicit bias has contributed to that. And one of the biggest things, in fact, is this anti-obesity bias in the USA specifically. So if you look at some of the trends, and again, we can get into the discussion about when we bring this forward to people and we make them aware, is this actually going to impact their awareness? And can this actually change the way people look at different groups? The answer is yes, it can. So you can see that there have been trends to have a reduction in implicit bias towards sexuality, race, and skin tone. Age and disability have seemed flat, but what we're also looking at is that there is an increase still in the implicit bias for weight. All the explicit biases have gone down, but for weight, it's still going up. And so this is a concern because we can see it directly impacts healthcare. Other people who are looking at this type of topic, there's a Stanford group that looked at it with criminal justice disciplines, careers, and they were basically teaching police officers about the idea of implicit bias, and they were doing script analysis of encounters with individuals, and found that the script analysis did show that the implicit bias was definitely affecting how they were interacting with individuals in the community. And the good news is that when they did interventions and educational sessions, that actually did improve the script analysis. So therefore, an intervention, making people aware, does have a benefit. So when we think about healthcare delivery, Again, many believe themselves to be free of bias who are delivering healthcare in various professions, but many studies have shown that these biases still do exist. Now, what about this idea of weight bias? We wanted to focus on that because of how widespread and common it is, because we see that it's still there, despite a lot of the cultural sensitivity training that's been implemented in basically every healthcare institution at this point. And obese patients have been studied, and they are hesitant sometimes to access healthcare because they think their provider, their physician, their nurse practitioner, their physician assistant, whomever is going to deliver care as a provider, will actually be prejudiced against them. Many people who have been studied who are obese have also reported actual adverse experiences that they themselves attributed to weight bias. So the thing is, the stigma of weight bias, unfortunately, has another correlate. It increases the rate of obesity development. So the obesity stigma itself, in addition to driving healthcare disparities, can also support the idea that people become and remain obese in the long term. So we're trying to fight obesity. We're talking about increased physical activity, healthful diets, and so on. And yet this stigma can actually be a big barrier to all of those efforts. So it's well worth thinking about in terms of the general public as well as individual providers. So just a little bit of background on Project Implicit before Tracy takes over and talks about our actual study. We're seeing a lot more research on this area in terms of implicit bias or unaware bias, both in healthcare professionals of different disciplines as well as students in other disciplines. The studies indicate that the bias extends to students as well as providers of healthcare, and there are studies out there in the literature on physicians, medical students, registered dietitians, diagnostic radiographers, pharmacists, nursing. So it's across the board in healthcare. It's not discipline specific. And so this is very disturbing to a lot of disciplines who felt that they were somehow above this automatic judgment process. And again, part of the implications for educators is that this is an awareness issue. It's an intervention to adjust behaviors, but not necessarily to remove the automatic judgment process, because that's pretty much impossible. You're going to make those judgments, but being more aware of them and then adjusting your behavior is really what we're looking to see. So we'll talk about our study next, and Tracy will now take over.
Thank you so much, Claire. Our interactive question, if you want to participate, have you used any of the Harvard Implicit Association tests in your work? And if so, what were the student perceptions and how did you use them? So I'm going to be talking, and then our other presenters will be monitoring the chat box. So next slide, please. Okay, so implicit weight bias involves rapid and automatic responses to obesity, and it can affect the well-being of oneself as well as others. And there is a need, as Claire mentioned, for increased awareness of unconscious bias against obese individuals so that we can provide culturally appropriate care. And as we all know, obesity is increasing so much every year in the United States, and we need to provide the best care to all of our patients. So one thing that we have found is that encouraging students to become more aware of their unconscious bias is important, and becoming aware of their bias can be accomplished with implicit bias testing. Next slide. Some of the strategies in healthcare education to combat bias against obese patients include having learning activities to promote positive experiences with obese patients, for example, in the clinical setting or at screenings in the community. Also eliminating discriminatory behavior by faculty and medical residents. It may be difficult to believe, but sometimes faculty can exhibit discrimination as well. And also changes to the curriculum, that would be another strategy. Next slide. What are some strategies for healthcare providers? So first of all, recognizing conditions that are associated with obesity, such as hypertension, diabetes, and other healthcare conditions. Also communicating that obesity is not a character flaw. Also educating patients that even small weight losses can lead to large health benefits. A lot of times, I work as a nurse practitioner as well as teaching. A lot of times I'll talk to patients and I'll encourage them, you know, even losing 4 or 5 pounds can really make a difference in blood pressure and blood glucose results. Another strategy is creating an environment where it's comfortable for overweight and obese patients. For example, chairs that are armless so it's comfortable for them, having appropriate equipment such as large blood pressure cuffs, having gowns that actually cover the patient. Those are things that sometimes you might not think about, but they can make the obese patients feel very uncomfortable. Even the words that we use, so more hurtful words are things like fat, morbidly obese, or chubby. Some less hurtful words include unhealthy weight, high BMI, overweight. So those are some things, and I know a lot of times I'll talk about BMI and whether the weight is healthy or unhealthy when I'm talking to patients as well. Next slide, please. So Claire had mentioned earlier about the implicit association test. So the IAT measures unconscious beliefs that are held by people. And the IAT has been used a lot in other fields, but it really has not been used as much in nursing research. That was something we found when we did our literature review. And the IATs are reliable, valid tests, and they provide useful data in nursing research. Next slide. So the main purpose of our study was to determine whether nursing students' explicit beliefs about weight preference were consistent with the implicit attitudes from the IAT, as well as to obtain student perceptions about the IAT test. A second purpose was to determine if weight bias is associated with the person's own weight category as determined by the BMI calculated from their self-reported height and weight. And I do have a link here to our published study from last year if you want to review that. And one thing I would point out about the students, they were first semester junior level undergraduate nursing students. Next slide. So the study was a public liberal arts university in the Southeast United States, and it is a residential college. We do have commuters as well, but it is primarily a brick and mortar university, and our nursing building is actually pictured at the bottom of the screen. And these were first semester students, and most of them had no healthcare experience prior to coming into nursing. So we did a pre-survey and post-survey that was anonymous. We did it on paper that included demographic information, their predicted weight bias, cultural competence, and communication prior to and after completing the Harvard IAT. And this was adapted from an existing 12-question survey with permission from the authors. Next slide. So this is just the survey that we used for questions 1 through 7, and these questions were the same in the pre and the post survey, and these were a Likert scale. And some of the questions include, I feel comfortable interacting with people of diverse backgrounds. I recognize assumptions that I may make about different groups of people. I can accurately assess a patient's prospective healing and medication therapy during an encounter. I can effectively counsel a patient who's from a different background than my own. So I didn't read all of the questions, but that's a sampling of those questions. Next slide. Now, question 8 varied on the pre-survey and the post-survey. So in the pre-survey, we were attempting to find out what their predicted weight bias is. And they had to choose which statement best described them, whether they prefer fat people to thin, I moderately prefer fat people to thin people, slightly prefer fat to thin, like fat people and thin people equally, slightly prefer thin to fat, moderately prefer thin to fat, I strongly prefer thin to fat. So that was in the pre-survey. In the post-survey, we were finding out their actual IAT results. So the students then listed what their actual IAT result was. Next slide. Okay. Now, Pam is going to go into the results of our study.
Thank you. For the survey, the demographics, we found that there were 69 out of 77 students who took both the pre-survey and the post-survey, so the response rate was pretty high, 89.61%. The self-identified gender, we had 10 males and 59 females, so very heavily weighted towards females. The self-identified ethnicity and race, Caucasian, 56, African-American, 10, 1 Asian, and 2 who identified as other. The BMI, we didn't collect a BMI per se. We collected height and weight and calculated the BMI. The range was 18.14 to 38.41 with a mean of 24.77 and a standard deviation of 4.3118. So the average overall was in the normal weight category. You can see the weight categories listed here for BMI. You can see that in the normal range, most of the sample was normal in that normal range, 40 out of the 69 people. Next slide, please. Oh, okay. The pre-survey results were compared to the post-survey results, specifically with regard to the IAT. I did a Wilcoxon signed rank test to look at the difference and determine if it was significant between the statements, the pre-survey statements of preference and the actual IAT scores. And we found that there was a statistically significant difference between what they thought their score would be and what their score turned out to be. You can see on this table what in the columns, it's what the IAT score said, and in the rows, it's what the person thought their result would be. So you can see if you look on the diagonal, we had one person who said they preferred fat and the IAT agreed with them. The second column, no preference. Quite a lot of people thought that they had no preference, but 11 of them were correct as far as the IAT was concerned. And then in the last column, the thin preference, 9 people predicted that they would have a thin preference, and that's what their IAT result was. And for everybody else, their IAT result was something different than what they thought it would be. Next slide, please. Okay, so here are some details about that. For those who predicted that they were neutral or that they had no weight bias, that was 56 out of the 69 students who really felt that they had no weight bias. But their actual results show that only 11 of them really had no bias. And those who were incorrectly predicting the weight bias, of the 45 people who incorrectly predicted their lack of weight bias, 5 had some degree of preference for fat people over thin people, which was in the minority, and 40 had a preference for thin people, and they thought that they had no preference. And for those who correctly predicted their weight bias, 21 out of the 69 students correctly predicted their weight bias. 11 indicated that they were neutral, had no preference. 9 correctly predicted that they had a thin preference. and one correctly predicted a fat preference. And of the students who recognized that they had some kind of weight bias, 3 of them were not correct about the direction of their bias. Next slide, please. We found that there was no correlation between weight preference towards others and the person's own BMI. So we thought that maybe if you had a BMI in a certain range, you would have more of an affinity and an acceptance of other people who had that same range, but that was not the case. There was just no relationship there at all. The next one is the thin preference IAT results. There was a significant Spearman correlation, which indicated that participants whose IAT score showed a preference for thin people were more likely to be surprised by their score and to find that it was different than what they thought. And then the overall weight bias, the majority of participants exhibited more weight-related bias than what they thought they had. We also did a qualitative analysis, and there was one open-ended question, and we found that there were 3 themes that emerged from this: awareness of personal beliefs and stereotypes, a reminder to be impartial, and skepticism about the IAT. Next slide, please. Okay, here's some more details about those 3 themes. Under the theme of awareness of personal beliefs and stereotypes, this is about the students' recognition of potential bias despite self-assessment to the contrary. And here are 2 quotes. "It was an eye-opener on how I really feel about fat versus thin. And you could change your views and be able to better perform care." The second theme is a reminder to be impartial. And that is about the importance of impartiality towards patients in the delivery of care. 2 quotes. "It can help me recognize bias and help everyone equally. And it makes me more aware of my feelings towards certain people. My nursing care should be equal towards everyone." And finally, quite a few people had the skepticism about the IAT. They just felt that since it didn't agree with what they thought, that it must not be valid. And we have 3 quotes to show how the type of response we got for that. "It will not influence me because I see people the same. I feel it does not accurately reflect feelings. And I don't see how the pictures and words correlate to preferences to people and their appearances." And that's the results. We'll go next to implications.
Okay, so anyway, I've been looking at the chat box and really glad to see that a lot of other people have actually looked at some of this in their own work. And one of the things that, as Pam was discussing, that we see here in our study and has also come up in other studies is just because you yourself belong to the same group does not necessarily mean that you would have a preference for that group. You may, in fact, also have an unconscious bias against that group. And so again, this can be towards any characteristic that you might want to study, whether it be gender, whether it be race or ethnicity, skin tone, socioeconomic class, religion, anything that's readily identifiable And depending upon your setting, different things might be readily identifiable. You might not think that you can readily identify a religious belief, but I spent most of my early life in New York City, and we had a very large group of people who were of different Jewish faiths and Jewish denominations, rather, and some of them were wearing items of clothing that readily identified them. You can also see that other faith groups may also, faith traditions may be wearing items of clothing that clearly identify their group. So even though you belong to that same group, you may in fact have a bias against them. So where's this coming from? And again, you've heard things all your life, you've seen things on the media, all of those things are going to influence these automatic judgments. But again, since they're automatic and you're unaware of them, it may be a real, yes, I'm looking at Evan's quote in the chat box. We should get Evan to sing possibly, that would help. The thing is that it's a real eye-opener for some people, and what we had going for us when we think about how to maybe take some of these results and utilize them in our teaching is that what we had going for us is that in general, when we're looking at healthcare, all the disciplines in healthcare, people typically are coming in with a predisposition to treat others in their care equally and to not administer care in any type of prejudicial or inequitable manner. So for the most part, as you could see from the comments that we got on the qualitative analysis, people felt that they had their eyes open. They recognized that, okay, this is something I should be aware of and want to be aware of, and how can I change this? They're actually going to reach out and ask, how can we change that? So you can have learning activities that can support the desire of students to actually address this issue. Seminars, assigned reading, simulation training. It doesn't also have to be standalone separately. Sometimes when you do standalone things and it's not integrated into the subject content, it may not be something that is translatable when they're actually looking at their subject content that they're going to use directly apply in their disciplines. So if you can incorporate the activities into existing content, that would emphasize how you can translate that to the mainstream application. It's important also that when you are an educator and you're dealing, if you choose to do, let's say, testing such as this and then take these results into your classroom, some studies have looked at this and found that a possible adverse outcome, possible negative issue is that students wind up being categorized as pro or anti, pro or against. And that actually creates a defensive characteristic and again, places a barrier to their learning or to any modification. So in education, trying to avoid, again, having the students feel that they're being categorized and to explain really clearly that this is just part of the human condition. To make automatic judgments is actually very important as part of the curriculum development. One of the things is that if they don't feel that the IIT results are valid, you may not get any acceptance at all. But there still may be considerable distress regarding the results, which is something, again, that I experienced and didn't expect to, and I had to deal with that sort of on the fly, so to speak, beyond just-in-time teaching, more than just-in-time teaching, but you know, dealing with putting out a fire that I created myself. So thinking about this in advance, that there may be a lot of distress that arises, and knowing how you're going to deal with that distress in your students is something really, really important to think about when you're creating or developing curriculum. So creating opportunities for discussion, encouraging self-reflection, and talking about why it's important, showing them objective evidence that it's not just this group, but it's very widespread, many other groups, many other disciplines, that can be very, very helpful. Again, explaining the neuroscience, just like we always say about patient care, if you can explain to a patient that the reason we're asking you to do certain interventions, whether it's a medication or a non-drug intervention, such as a lifestyle change, why that would actually be a benefit because of the known biology involved, can actually create a better acceptance and a better adherence to your goal of having them adjust their behaviors to account for these biases. And now, as I said, one of the benefits that we've seen from research in the area is that in the past, it was thought this was something that could not be changed, that these implicit biases were automatic judgments, that no matter how much they were brought to the awareness of the individual, that they would still remain in place and be immutable. This has been demonstrated to not be true, that with direct application of some of the strategies that I mentioned in the previous slide, you probably can get people to have some change in their behaviors and possibly even their awareness and therefore their actual biases and their thinking. So it can help reduce unconscious prejudicial behaviors, and in our case, in terms of healthcare, that is the outcome to be desired. So one of the things we would say, based on our research and the research of others, is that we would say consider using validated testing. They are available free of charge. They're web-based, so you don't have to go out and print up papers or worry about being face-to-face. They're digital. And maybe just use the results to understanding the results in the context of whatever diversity or cultural sensitivity activities that you are actually implementing in your classroom. So we wanted to thank you for attending our session. We're entering the Q&A time, as Cindy is reminding us. And so we have our emails there if any of you would like to contact us, and we'd love to hear your thoughts on this topic and our research.